We're going to talk now about a case with a patient who developed preeclampsia with severe features and postpartum hemorrhage. So this patient was 38 years old. She was a gravida 2 para 0101, and she was at 37 weeks and 4 days. She had an obstetrical history that was notable for one prior vaginal delivery, and she also had developed chronic hypertension during the pregnancy. Her fetus was also on ultrasound noted to be macrosomic with an estimated fetal weight of 4359 on a recent ultrasound. So notable risk factor for hemorrhage. Of course, we discussed with her precautions around shoulder dystocia at the time of her admission. And she actually came to us after having ruptured membranes earlier that morning. So for her course on the labor floor with us, as I mentioned, she had ruptured membranes, had leakage of fluid early in the morning, which shortly thereafter she started to feel some contractions, and she presented to the hospital. And during her initial evaluation in the triage unit, was noted to have severe range blood pressures as well. So she was immediately transferred to us and for admission. And after some lab work was done and additional blood pressures were taken, she did rule in for a diagnosis of chronic hypertension with superimposed preeclampsia with severe features. So she was started immediately on magnesium sulfate for seizure prophylaxis, notably another risk factor for hemorrhage. And she was continued on her home blood pressure medications, which at the time was 30 milligrams of Procardia. During her course, she was already in latent labor, requesting an epidural for pain management, and we then started Pitocin to augment her labor. She had a very normal labor curve, and once fully dilated, she pushed for just 30 minutes or so before delivering a viable female infant weighing 4290. Thankfully, no shoulder dystocia was experienced, and there were good APGARs of 7 and 8. So soon after delivery, she started to have very brisk bleeding. And actually, we ended up doing a manual extraction of the placenta due to this brisk bleeding. Her uterus was very atonic. And so we did our typical fundal massage. We started IV Pitocin. She also got Hemabate and some buccal misoprostol, as well as an antifibrinolytic that was administered by our anesthesia team. Because of the fact that she'd had this retained placenta, or that not really retained, because we had done a manual extraction, we did a bedside ultrasound just to make sure that there was nothing that we were missing, that there wasn't some piece of the placenta still retained. And all we saw was some clot that was inside the uterus. So this was quickly removed. And the uterine tone remained poor at this time. So we then called for a JADA, and the JADA was placed about 17 minutes after the time of delivery. And upon placement of our JADA, we only had about 50 cc's after placement that went into the tubing and into the canister. So the vacuum was discontinued and the cervical seal was deflated about 3.5 hours after the JADA was initially placed. And the patient was monitored with the device in place for about another hour and 15 minutes or so. So in summary, what we had was a patient who presented to us with ruptured membranes, was diagnosed with preeclampsia, superimposed preeclampsia with severe features. And in that setting, she was started on magnesium sulfate and her labor was augmented. She had a spontaneous vaginal delivery that was followed by a postpartum hemorrhage. And ultimately, the total QBL for this case was 2,800 cc's. She received multiple uterotonics, and the JADA was placed about 17 minutes after delivery. And as I said with the case before, typically now at our institution, we would have placed that JADA earlier. Usually we now are doing it after the first or soon after the second uterotonic if we are still experiencing atony. And as we look at this timeline, it's kind of good to also think about some of the studies that were put out, the original studies on JADA. Just comparatively, we know that the data from the Pearl study, which looked at effectiveness as well as timeliness, showed a median time of about 3 minutes to control bleeding. And it's hard, we don't really have that level of data to know exactly how long for this case, that it took before we had controlled bleeding, but it's always within minutes. It's very, very quick and kind of feels almost immediate. And for this case, the Jada was inserted for about 3.5 hours before discontinuing the vacuum, and our total indwelling time was just under 5 hours. It was 4 hours and 45 minutes. And in the Pearl study, the average time was about 2.4 hours for active treatment with the vacuum connected, and 3.2 of total indwelling time. So a little bit longer for this case compared to the average. So for this patient, her postpartum course was also notable for that superimposed preeclampsia with severe features. And so she remained on her magnesium for a total of 24 hours for seizure prophylaxis. And interestingly, her preeclampsia was quite significant. We ended up having to increase her dose of her Procardia up to 120 milligrams and added on labetalol as well, 200 milligrams twice a day to get control of her blood pressure. And she also did get some IV iron transfusion just to help with some acute blood loss anemia. But by her 6-week postpartum visit, she was doing really well. And we actually were able to stop her labetalol at that point.